Good afternoon, everybody. It's a pleasure to be here one more year with all the friends and review interesting topics. The topic we are going to discuss today is sudden death, but it's going to be discussed in a not really common way in the sense that the arrhythmologists always look at sudden death prevention in previous infarction, ICD implant, etc. And I think we have a real expert in ischemia, and that's David García-Dorado with a lot of experience. He works in Vall-d'Hebron in Barcelona. I worked with him many years ago, and it's a real pleasure to have David here with us to discuss about ischemia. And I think indeed what we are seeing with all the improvements that we have with treatment of acute MI, that more and more the sudden death occur in the context of acute MI, and we all see many patients with irreversible cerebral lesions in our CCUs. So it's clear that despite ICDs, despite all the things that we have created and the change that we have been seeing in the last years, this is still a major challenge when a patient has ischemia and has a sudden death. So I hope David can give some ideas about that. Thank you, David.
Thank you
no
to
se te oye un segundo. ¿Podéis el micro?
Thank you to the organizers for this very kind invitation. That is also a big challenge, because my main declaration of conflict of interest is that I am not an arrhythmologist, and I am quite ignorant in some of the details of the arrhythmias we are going to discuss. But we will agree that ischemia reperfusion is a source of ventricular arrhythmias. This is clear, and it is also clear that part of these arrhythmias are directly produced by ischemia and reperfusion that produces electrophysiological changes at the cell level and in the cell-to-cell communication that result in ventricular arrhythmias that kill a lot of people during the acute phase of ischemia. But even more importantly, ischemia reperfusion may cause necrosis, and this myocardial necrosis can cause adverse ventricular remodeling that may result in the substrate for late ventricular arrhythmias, in particular sustained ventricular tachycardia and ventricular fibrillation. And this is the topic I will talk on today. And this topic is exemplified by this patient. This is a 72-year-old man with 19 minutes of chest pain and anterior ST segment elevation on ECG on first medical contact. What is the present of arrhythmias treatment and prevention in these patients? Well, we will rush to the cath lab to perform stent this artery. We will treat this patient with antiplatelet, anticoagulation, secondary prevention. We will cross our fingers, trying to, hoping that he will not develop heart failure. And if heart failure occurs, then we optimize treatment. And if needed, according to guidelines, we can do CRT, P or implantable defibrillation therapy. And if there are certain circumstances, we can still apply tachycardia ablation. I think that we would agree that this is the present situation. But what is going on in this patient all this time? Here is an example of reperfused infarct in a pig. And we see that there is a clear delineation of the necrosis and salvaged myocardium within the ischemic area. And you see that there is a very sharp delimitation, and that the infarct can be very irregular, with intermixed areas of salvaged and dead myocardium. And this healthy myocardium is really healthy, and the necrotic myocardium shows contraction band necrosis. And there is a very sharp delineation between these two types of myocardium, so that at the cell level, there is no border zone. The border zone is the result of a mix of 100% healthy and 100% dead cardiomyocytes. And why this irregular shape? Many years ago, we demonstrated through three-dimensional reconstruction of histological sections and computer analysis and simulation that this is due to the fact that there is cell-to-cell communication in such a way that the fate of one cardiomyocyte influences the fate of the adjacent cell. It's like a fire in a forest. And it took about 10 years for us to provide an explanation of the mechanism of this propagation. And the propagation of cell death was through gap junctions and could be prevented by gap junction blockers. And in particular, what crossed the gap junctions was sodium that was then exchanged by calcium. So there were very rapid things happening during the first minutes of reperfusion, resulting in very irregular areas of necrosis that were also well swollen with a lot of edema. This is also an important aspect, and I will illustrate it with these videos of a big heart in which you can see the normal ventricular wall and what happened during ischemia. You see that there is thinning and dyskinesia, but only 5 minutes after reperfusion, what you see is this huge swelling and shortening of myocardium that persists for 2 hours and for days. And this is, How can I get out of the escape again? Okay. And you see that this is a very rapid change taking place during the first 5 minutes of reperfusion. It's dramatic. But things go on. And patients can develop then adverse post-infarction remodeling that is an evolution of this change. And the first thing that happens is that there is infarct expansion, and this results in increased wall tension and hypertrophy, so that although remodeling starts in the necrotic area, it involves the whole heart. But what is the more adequate definition of adverse left ventricular remodeling? We propose that this definition is the one that can be more useful to predict the outcome of patients. And there is so far no clear definition about whether it is increasing heart volume, in left ventricular volume, or reduction in ejection fraction, or both. So we followed almost 400 patients with 2 cardiac magnetic resonance studies during the first week after 6 months of a first acute myocardial infarction. There are very striking changes in the shape and the histology and the composition of the necrosis, but the important thing is that what really discriminates the evolution of patients are the changes in left ventricular volumes and ejection fraction, and these are independently predictive and additive. So you see that the risk of sudden death or infarction, or a heart failure in these patients depends on not only on increasing in the diastolic volume, but also of a reduction in ejection fraction. And these are additive. And what are the mechanisms of these changes? They are very complex, but I will only say that there is an acute inflammatory phase with leukocytes and pro-inflammatory monocytes followed by a healing phase with a different type of monocytes. And I would like to stress that fibroblasts are very important, and in particular, they are important when they became this kind of green monster that are the myofibroblasts that produce collagen and also do many other things that are pro-arrhythmogenic. And these are well known for arrhythmologists because these activated fibroblasts not only increase extracellular components, but also alter the electrophysiological function of cardiomyocytes by connected to them through gap junctions and acting like sinks. And this results in a slowed conduction and increased automaticity and are risk, a really important risk factor for arrhythmia. So I would like to sum up changes to adverse ventricular remodeling by saying that there is infarct expansion, extracellular edema, there is leukocyte and inflammation, and then healing. There is hypertrophy. There is an important element, which is myofibroblast differentiation, and there is remodeling of gap junctions and scar reinnervation. So what can we do knowing all this with our patient? What could we do in the future? The first thing we could do is to limit infarct size. When we interrupt ischemia with reperfusion, there is a reduction of infarct size that is limited by the occurrence of an accelerated necrosis during the first minutes of reperfusion. And this can be prevented experimentally with interventions, and this is what we call reperfusion injury. And it has been very difficult to translate it to patients. And actually, there are strategies like those based on the mitochondrial permeability transition and cyclosporine and other drugs that are completely failed. But there are other strategies that are working rather well with more than 12 consistently positive studies that as remote ischemic conditioning, which is the ischemia and reperfusion in an arm with a cuff during the last minutes of ischemia and during percutaneous coronary intervention, and other interventions that offer a future. So the first thing we could try to do is to reduce infarct size. The second thing is to prevent adverse remodeling if we have not been able to reduce infarcts. And I'm showing here two examples of these treatments. One is the application of an inhibitor of microRNA 92A. This microRNA inhibits angiogenesis. So if we inhibit the inhibitor, we have more angiogenesis, but we don't want to have it in the whole body, so we use microspheres to inject this into the area at risk. And you see that the result is quite spectacular, and we are trying to translate this to patients, but you see that there is a lot of angiogenesis and the inhibition of remodeling. Another approach is to inhibit calpains. Calpain can be inhibited with oral drugs and are activated by proteases activated by calcium. And in this study, we proved we tested different treatments, and I would like you to concentrate on this protocol in which the drug was started only after 1 day after infarction, when the infarction was already fixed and done, so that we could interfere not with infarct size, but with remodeling. And what you see is that with this protocol of oral chronic calpain inhibition, what you have in these animals is a reduction in left ventricular dilation, and even more importantly, a preservation of left ventricular ejection fraction, independent of infarct size reduction. We can also aim directly on myofibroblast. The effect of calpain actually is mediated through inhibition of myofibroblast activation. I haven't time to show it, but you can aim directly to this, and we can do it by inhibiting, for example, TGF-beta-1. You see that TGF-beta-1 has no effect in cell-to-cell communication among cardiomyocytes, but increases the communication through gap junctions between cardiomyocytes and fibroblasts. And this can be inhibited by inhibitors. This is a way to do that. But there are other ways. And this is a very interesting study in which the authors demonstrate that myeloperoxidase has an important effect on fibroblasts and arrhythmias. You can see that if in animals mutant without not being able either to have neutrophil accumulation or to have myeloperoxidase synthesis, there is a reduction of arrhythmias. And this reduction in arrhythmias is caused by two main mechanisms. One mechanism is the preservation of gap junction communication in ischemia reperfusion and also after permanent ischemia. And you see that the animals that cannot synthesize myeloperoxidase have a preserved communication and not a reduction in gap junction in distribution, connexin 43 gap junction. And this is not due to a reduction in the amount of protein, but it is due to an inhibition of the degradation of connexin 43 by matrix metalloproteinase 7. And the second effect is through inhibition of fibroblast differentiation into myofibroblasts. You can see here that animals that cannot, that are knocked out for myeloperoxidase have less activation and less fibrosis. And even if you look at the serum levels of myeloperoxidase in patients with acute myocardial infarction, and you adjust for important variables, in particular left ventricular ejection fraction that we saw that is the main determinant of the evolution of patients, what we can see is that the risk of ventricular arrhythmia, of sudden cardiac death, or the need of implantable cardioverter defibrillator is significantly increased in those with more myeloperoxidase. This is a study in 2,000 patients. It has many limitations, but it suggests that this can be an important target in the future. And we can directly aim to gap junction communication, not through myofibroblasts, but directly. And there are drugs, there are peptides that can maintain gap junction and increase gap junction communication and prevent remodeling of gap junctions in ischemic tissue. And we use, when you use those drugs, you can demonstrate a reduced inducibility of arrhythmia in animals without increasing infarct size, because this can be applied when infarct size is already formed and the size is final. And of course, as you know better than me, we hope that in the future we will improve our ability to detect the substrates for ventricular arrhythmia in scars. Of course, this will be done by imaging techniques and the merging of this imaging with electromechanical mappings, and there is a field of rapid growth here. But I would like to emphasize just one point. Well, we agree, of course, that this is not perfect now, and the maps we obtain and the images we obtain of channels are rough, but nevertheless, they are useful. But what I would like to stress is that it is possible to detect those low conduction channels very early after infarction, and so that we can act on them. In theory, we could act knowing that we are acting in channels that will remain in patients and can cause arrhythmias. And also, I would like to emphasize that late gadolinium enhancement is not the end of the story, and probably there will be other methods that can complement or even replace, in some patients, this technique. And this is the case of, for example, of diffusion tensor magnetic resonance tractography. And you can see that this method can differentiate between the scar and the normal myocardium, but also can predict bipolar voltage in a very accurate way. And finally, we can do other things like, for example, limiting sympathetic stimulation. And here we have an experiment in which animals were submitted to sham or real renal denervation. And you see that when renal denervation was real, as you can expect, there is a real reduction in the innervation of the scar. And this was associated to a marked reduction in post-infarction, spontaneous post-infarction arrhythmias. So what can we do? What could we do with our patient in the future? Well, maybe, well, not maybe, for sure, we will do the same that we are doing now. We will rush for angioplasty and stenting. We will do essentially the same, but in addition, we could probably in the future offer this patient infarct size limitation through additional treatment supplied at the time of reperfusion. But we could also add specific treatments that could reduce remodeling in this patient. And we could also limit sympathetic stimulation. We could prevent myofibroblast arrhythmogenicity through different strategies, or we could even directly maintaining connecting 43 cap junction communication. And of course, we could have in the future a very accurate and predictive map of channels in a patient that could offer, in theory, the possibility of act prophylactically on them, so that we could resort to the defibrillator only if everything else fails. So this could be a change in the future for our patient, but we don't know how many of these points will be true and how much we will have to wait for them. In any case, thank you very much for your attention.
Thank you, David. We'll proceed with the discussion at the end of the session. And it's a pleasure for me to introduce Professor Hauer, so many years working in the field. It's a great honor to have you here. He's, of course, a colleague and a friend for many years, and he has been so kind to come here to discuss with us about the other large family of arrhythmias that are not related to ischemia, and particularly arrhythmogenic cardiomyopathy, which are the options, and how can we prevent sudden death in these patients. Thank you, Richard.
Well, thank you, Dr. Mont, Dr. Di Marco, ladies and gentlemen. First of all, I'd like to thank the organizers for inviting me to this intriguing city with so many cultures mixed together, and also an invitation for this excellent convention. The topic that I have to discuss with you is arrhythmogenic cardiomyopathy, and more specifically the treatment options and sudden cardiac death prevention. How do we define arrhythmogenic cardiomyopathy? And I think the best definition for that is it is a heart muscle disease starting with ventricular arrhythmias in the early stage of the disease, followed at later stages by cardiologically identifiable structural and functional disorder at later stages, and that makes it belonging to a different category as those with dilated cardiomyopathy, where the structural and functional diseases come first, usually. There are subcategories of this arrhythmogenic cardiomyopathy, and that's related to the diagnosis. If we look at predominant right ventricular disease, or the classic or typical arrhythmogenic right ventricular dysplasia or cardiomyopathy, it is a diagnosis by fulfillment of the revised 2010 task force criteria published both in Circulation and in the European Heart Journal. And I don't go to all these details of that. And on the other hand, we have biventricular or predominant left ventricular disease, for example, those with desmoplakin mutation and phospholamban mutation carriers. And there, the diagnosis by the revised task force criteria may be insufficient, since these task force criteria are focusing on the right precordial electrocardiographic leads, V1 up to V3, and that may be insufficient in this type of subcategories. This is a typical arrhythmogenic right ventricular dysplasia. And if we go first to panel A, I don't know how, yeah. Into panel A, we see a normal left ventricle at the right side of panel A, and on the left side, the right ventricle, where you see typical involvement, and that's enlarged in panel B, where you see that this right ventricular wall is affected with a fibrofatty alteration and aneurysm formation more in the apical region. And here in the lower panels, these are the typical fibrofatty alterations. I don't go into these details. However, on the other hand, we have here an example of a biventricular disease in a patient who died from a phospholamban mutation. And we see in panel A the right ventricle and the left ventricle, and both are involved. In panels B and C, we see the histology of the right ventricle in panel C enlarged, as we see again the typical fibrofatty alteration in the right ventricle. However, in the left ventricle, in panel D and E, we see a similar pattern of, in red, the still vital myocardial fibers embedded within fibrous and fatty tissue. And this is another example. This is from the Padua group. Here we see the left ventricular histology of a 15-year-old sudden cardiac death victim with a desmoplakin mutation. That patient was seen, I think, a couple of months before without any evidence of the criteria for arrhythmogenic right ventricular dysplasia diagnosis. However, at autopsy, he died suddenly. At autopsy, there was tremendous involvement of the left ventricular wall subendocardially, where you see again that fibrofatty alteration. What is the age of the patient who dies suddenly from arrhythmogenic cardiomyopathy? And this is the first study that looked more specifically to that. That's from Bill McKenna's group. He looked at the histology in these patients who died suddenly. And these are 45 patients with pathologically proven arrhythmogenic right ventricular cardiomyopathy. And we see here the different age categories from 10 years up to 70 years. And you see the half of these 45 patients died before the age of 30 years. And more important, it is that it's often the first manifestation of the disease. So they had no real complaints before, and so it occurred really unexpectedly. And we have the very similar results. This is a study, from a combined study from Johns Hopkins and from the Netherlands, and we see a comparison between pediatric patients defined as those who presented with arrhythmogenic cardiomyopathy before the age of 18 years compared to the adults. So 75 patients in the pediatric category in red, and in black, the much larger population presenting in the adult stage. And here you see if you look at the sudden cardiac death and resuscitated cardiac arrest as presenting symptom, that's about a quarter of all the patients who are below the age of 18 years presented with sudden cardiac death or resuscitated cardiac arrest, whereas stable monomorphic ventricular tachycardia is the typical arrhythmia presenting in adults. What are the treatment options? First, lifestyle is important. We know that vigorous exercise reduction is very important, and we know the important role of exercise from experimental studies in mice. I come to that later. Then we have pharmacologic options, antiarrhythmic drugs and beta-blocking agents, and they really may very importantly reduce the number of episodes. However, we have to realize that they are not protecting against sudden death. There are no real studies that support the pharmacologic drug treatment in the protection against that. Catheter ablation, very similar. It started with endocardial approach, now with epicardial and combined approaches that show better results. I also come to that later. Also there, it may reduce the number of episodes. However, we have to realize that in a large study from the Johns Hopkins group, it appeared that after 5 years in a large group, about 50% had again sustained arrhythmia episodes. Then the defibrillator, the ICD, is at the moment the only device that can really reduce the mortality. Then we have other not well-developed options. The sympathectomy is described in case reports, but there are no real studies about that. And future alternatives are very interesting. Let's say this study from Jeff Suffolk's group at Harvard, they look at GSK3 beta inhibition and showed that all the signs of arrhythmogenic cardiomyopathy can be just blocked by these drugs. However, it's a carcinogenic drug, so there are no reports of the use in patients at the moment. This is what I promised you about exercise, the study by James. She looked at a comparison in Kaplan-Meier curves in green athletes and in blue the non-athletes. And if you look here at the occurrence of arrhythmias at the left side, panel A, we see that the non-athletes are doing much better than the athletes. And the same in panel B is for the heart failure. So exercise is doing worse also in the progression of the disease. And this slide shows the distribution of fibrosis in different cardiomyopathies. This is in the control situation, panel A, all the red areas, normal myocardium, and then the other panels show different cardiomyopathies. For example, here in panel F, we have a patient with hypertrophic cardiomyopathy with a sarcomeric mutation, and you see that there is subendocardial fibrosis. Subendocardial fibrosis. However, in phospholamban, as well as in desmosomal mutation, you see a subepicardial starting of the fibrofatty alteration process. And the other, desminopathy and lamin, they are also different. So it may explain the reason why epicardial ablation has a higher success rate than endocardial ablation alone. This slide is again from combined studies from Johns Hopkins and from the Netherlands. Here we see more than 400 proband patients in a large combined study with a follow-up of 7 years. And please focus on this aspect, the occurrence of cardiac arrest in 23 patients who presented just with sudden cardiac death, and the diagnosis was made at autopsy, and 25 patients were successfully resuscitated. So in total, 11% of this really large group, I think this is the largest group of probands in the world, 11% presented with sudden cardiac death. The other thing that I like to focus you on is the treatment with the defibrillator. And please follow these little arrows here and there. Those are the patients treated with a defibrillator. 10 out of 335 with a defibrillator died at the end of follow-up. And on the other hand, if you look at those without the defibrillator at the left side, 11 of 63. That means that there's a more than 5 times higher risk of dying suddenly without a defibrillator combined with the defibrillator carriers. This slide shows in the same study a comparison in relatives. Oh, I'm sorry, I was maybe one back. Yeah, this is a comparison in probands in the same study, and please focus these Kaplan-Meier curves in panel A and in panel B. In panel A are mutation carriers, in panel B the non-mutation carriers, and focus on the red line and the blue line. The red line is the occurrence of sustained ventricular arrhythmias, the blue line is the mortality line. And you see a very similar pattern if you look in probands, you look at mutation carriers versus non-carriers, you see a very similar pattern, although the event started earlier in the mutation carriers. Very different is the situation in relatives. We have more than 500 relatives of these probands. And again, focus on the red and the blue line. Now you see that the mutation carriers are doing much worse than the non-mutation carriers at the right side. This is a comparison of having only a single pathogenic mutation or multiple mutations. The carriers of multiple mutations in our study did really worse, and that was previously also shown in a smaller group by the Padua group. This slide shows the left ventricular dysfunction defined as a left ventricular ejection fraction below 55% in probands in the left panel and in family members in the right panel. And it shows you the tremendous difference in, if you compare the plakophilin 2 mutation carriers, the percentage of those who have left ventricular dysfunction is much less than, for example, with the phospholamban mutation. And you see a similar pattern in family members. So the phospholamban mutation is much worse as far as left ventricular dysfunction is considered, and the others are in between. This is also shown before, and we confirmed that again, that male patients are doing much worse than the female patients. Then we go to the phenotypic analysis. Are there phenotypic signs of risk? This is a study from the Padua group showing if you have no risk factors, no phenotypic risk factors, you are doing well, even if you are a mutation carrier, a pathogenic mutation carrier. But as soon as you have at least one risk factor, you are doing much worse. Well, this is one of these factors. That is the number of premature ventricular complex on 24-hour Holter recording. And in green is those who have appropriate ICD intervention. And you see here the different categories going from less than 305 up to more than 6,000 premature ventricular complexes per 24 hours. And you see the more ectopy you have, the higher the chance of an appropriate ICD intervention. Very similar for non-sustained ventricular tachycardia. If you have a non-sustained ventricular tachycardia, you are doing much worse than without that. This is the inducibility at an electrophysiologic study. Again, you see inducibility of a sustained ventricular tachycardia means you are doing worse. This is important to look at the cumulative effect of risk factors. And these risk factors are here: the proband status, inducibility of a sustained ventricular arrhythmia, the occurrence of a higher number of ventricular ectopy, and the occurrence of non-sustained ventricular tachycardia. And at the left side, we see any two risk factors, any three factors, or four factors, and you see that they are doing much worse as far as the occurrence of sustained arrhythmia is considered. Maybe more important is to look at the right side, where we only looked at those who have ventricular rates at interrogation of the defibrillator of more than 250 per minute, what is more related, we suppose, to sudden cardiac death, and you see a similar pattern. Also is looked at the 12-lead electrocardiogram. 12-lead electrocardiogram, and this is an example of very advanced arrhythmogenic cardiomyopathy in a plakophilin-2 mutation carrier in this case. And you see here that there is a terminal activation duration from the nadir of the S-wave up to the end of all depolarization deflections being 110 milliseconds in V2. You see also that there are discrete signals that may be identified as epsilon waves that are a major criterion in the task force criteria. Then you see, as far as repolarization is considered, you see that there are negative T waves in V1 up to V5, and also that is a major task force criterion. And in addition, you see also late activities in 2, 3, and AVF. This all is typical for a very advanced stage of arrhythmogenic cardiomyopathy. So, and Bonzale published a sort of triangle to identify those with low risk and those with high risk for sustained ventricular arrhythmias. Low risk are those family members with a low or intermediate risk of the electrocardiogram, and I don't go into all these details, or family members with a high-risk electrocardiogram and less than 10 premature ventricular complexes on a Holter recording. On the other hand, we have probands with a high-risk electrocardiogram and those with a high number of ventricular ectopy, typically at high risk, and the others are in between. However, it is not only electrical where we have to look at. This is a study from Terila from our group, where she looked specifically at those with only electrical abnormalities on electrocardiogram and Holter recording, and those with, in addition, fulfillment of structural task force criteria. And then if you have also structural disease, you are doing worse than only electrical. Here are the risk factors again in arrhythmogenic cardiomyopathy: genetic factors, proband status, male gender as already discussed, multiple mutations, then the specific mutation, desmoplakin and phospholamban, with much more left ventricular involvement than the plakophilin-2 mutation carriers, and also in the desmoplakin mutation carriers, we have a higher incidence of the occurrence of sudden death than, for example, the plakophilin-2 mutations. The environmental factors, the vigorous exercise is really a risk factor. Then the symptoms and phenotypic signs, non-sustained ventricular tachycardia, a high amount of premature ventricular complexes, high-risk electrocardiogram, inducibility of a sustained ventricular tachycardia or ventricular fibrillation, unexplained syncope, not discussed, but it's also an important one, accumulation of multiple risk factors, and right ventricular or left ventricular dysfunction. This is from a recent study in a large international consensus group looked at high risk versus low risk. The high risk group here is aborted sudden cardiac death at the left side in red due to ventricular fibrillation. Those who have sustained monomorphic ventricular tachycardia, severe dysfunction of the right ventricle, left ventricle, or both. Typically in these patients, a defibrillator is indicated. On the other hand, at low risk, if you have no risk factors, or you are just healthy gene carriers, but keep in mind that although you may have no symptoms at all, you may die suddenly. That's still really a tremendous problem. There's no defibrillator indicated, but not in all, I think. Then we have the intermediate risk group in between again. In summary, ladies and gentlemen, arrhythmogenic cardiomyopathy is a cardiomyopathy with predominantly right ventricular, left ventricular, or biventricular disease with ventricular tachycardia or fibrillation at the early disease stage. Sudden cardiac death is frequently the first disease manifestation at young age. Lifestyle improvement, drugs, catheter ablation may reduce ventricular tachycardia episode, but again, only ICD at the moment prevents sudden cardiac death. There are no data that the other treatment options really reduce the sudden death incidence. Genetic, environmental, exercise, and phenotypic signs and accumulation of signs contribute to risk assessment. However, more accurate individual risk assessment is needed, particularly for sudden cardiac death prevention. And we have to realize identification of a pathogenic mutation is the first step in the prevention of sudden cardiac death as first disease manifestation in asymptomatic family members. And finally, this is in preparation. We are working on in a large multi-center study, including the US, Canada, Scandinavia, and Switzerland, where we have 50% patients from North America and 50% from Europe, more than 500 definite patients with arrhythmogenic cardiomyopathy fulfilling the task force criteria. And we looked specifically at the factors sex, age, recent syncope, non-sustained ventricular tachycardia, the PVC count, and the number of leads, anterior plus inferior, with T-wave inversion and right ventricular ejection fraction. The left ventricular ejection fraction, although a risk factor, is not studied because it is in a relatively small group. And also you don't see here the typical mutation carriers that are particularly dangerous, such as the desmoplakin mutation and the phospholamban. So this is primarily where we look at the creation of a risk calculator for individual risk assessment per patient in the group predominantly with plakophilin-2 mutation and non-mutation carriers. Well, that was it. Thank you very much for your attention.
Well, now it's really a pleasure to have with us Dr. Cristina Basso, who everyone knows as one of the major international experts in the issue of sudden death. She comes from Padova in Italy and from a group that has provided several seminal papers on sudden death in different cardiomyopathies. So it's really a pleasure and an honor to have you here.
So thank you for the invitation, and thank you. Of course, it's a pleasure to be here. And I'm not dealing with cardiomyopathy this time. So I'm dealing with a strange disease, mitral prolapse, which is usually considered a benign. Can I have my slides? Okay, a benign condition. Why we're speaking about mitral prolapse in a session devoted to restratification and arrhythmias. So, first of all, we must recognize that mitral prolapse is not just a single disease. We should start really with the definition of the entity, then to try to understand how you can identify the arrhythmic variant of the mitral prolapse, and if is there a substrate explaining in a subset of patients dialectic instability, even at risk of ventricular fibrillation and sudden death. So let's start with this definition. I forgot to tell you that no conflict of interest because I was a cardiologist many, many years ago, and then since 20 years I'm working in pathology, so there is no conflict of interest at all in terms of electrophysiological, of course, correlation. And so let's start with the definition of prolapse. From the perspective of the pathologist, we cannot speak about prolapse. We are looking to the valve, it's not moving, so we can say what is going on in the leaflets. What is going on is an excessive tissue. You can see here the redundancy of the leaflets. They are thickened not because of fibrosis, but because the collagen and the fibrous tissue is replaced by mucopolysaccharides, protoglycans, and this explains why there is also an elongation of the leaflets and an elongation of the choroid tendine. There are many synonyms in the literature, the famous Barlow disease, but also mucinous, myxoid, or myxomatous degeneration. The mitral valve or mitral leaflet click murmur syndrome. This is an auscultatory and electrocardiographic also definition, the hooded mitral valve. But anyway, you're referring to this valve, not just the displacement of the leaflet, the one that you can catch by echocardiography, but really a structural abnormality of the mitral valve. So if you now look to the definition of the Framingham study, this is a famous paper published in 1999 in New England Journal of Medicine. Instead, the classical mitral valve prolapse is defined as a displacement of the leaflet more than 2 millimeters towards the left atrium compared to the atrioventricular junction, and there is a thickness of the leaflets measured by echocardiography more than 5 millimeters. But then there is also is included also a non-classical mitral valve prolapse, again with displacement more than 2 millimeters, but with thickness less than 5 millimeters. So you put together, so prolapse is just the displacement of the leaflets toward the left atrium, and according to this echocardiographic definition, you can have a prevalence in the total population of 2.4%, which is less than in the past, but is still an important number. And if you look to the conclusion of the famous paper, the prevalence of the adverse sequelae commonly associated with the mitral valve prolapse in study of patients referred for that diagnosis was low. So very benign condition according to this definition. So why we are speaking now about arrhythmic mitral valve prolapse? Because not everything is the same, okay? The general definition, epidemiological data are based upon the general definition, so prevalence of 2–3%, but this definition is neither representative of a cardiac disease nor the nosographic entity we are referring to with the term of arrhythmic mitral valve prolapse. So what is arrhythmic mitral valve prolapse, or the arrhythmic variant of mitral valve prolapse? Nothing new, because if you go back to the literature of the 70s and the 80s, there are many publications describing the auscultatory and electrocardiographic syndrome, and this is the classical panel that you can recognize in many papers. The title is Ventricular Arrhythmias in Syndrome of Balloon Deformity of Mitral Valve, and the authors were already looking for the possible restratification, how to identify a subset of patients with an high risk of arrhythmias. Again, if you look to the literature, which is the prevalence of arrhythmias? Isolated premature ventricular beats ranging from 58 to 89%, ventricular couplets from 6 to 50%, triplets or ventricular tachycardia up to 21%, so quite a different series. Why so different number? Because there are different entry criteria. We will be back to this aspect. Again, as far as the risk of sudden death in mitral valve prolapse patient, living population followed up during years, you see that we are ranging from 0.1 to 0.4% sudden death per year in patients with a clinical diagnosis and echocardiographic diagnosis of prolapse. What about the electrocardiogram? Nothing new. Publication 96. It's not easy to read, but there is a column, the one with the red line, 12-lead electrocardiogram. You see that among the feature reported, you have U waves, you have inverted T waves as T changes in the inferolateral leads, so already in 76. And then another publication in the 80s pointing on arrhythmias, sudden death in mitral valve prolapse, potential risk factor for sudden death. You have all the list, complex ventricular arrhythmias. Of course, mitral regurg, I didn't speak. If you have a severe or moderate regurgitation, so not just prolapse, but also an hemodynamic impairment, there is the problem of the left ventricular remodeling and the arrhythmias linked to the left ventricular remodeling. But except for this situation, you can have a prolonged QT interval, inferolateral repolarization abnormalities, redundant leaflets, history of syncope, presyncope, and palpitation. So, summing up, variable prevalence according to the definition, according to the population studied, including or not mitral regurg, which is very important, and complexity of ventricular arrhythmias. The clinical evidence of hemodynamically important regurgitation greatly affects the occurrence of ventricular arrhythmias. Then an important information, even early electrophysiological studies demonstrated that the most common site of arrhythmias, premature ventricular beats, is the inferobasal portion of the left ventricle, exactly the one that you can inspect by electrocardiogram with the inferolateral leads. And then finally in 2013, if I remember well, there was the famous study by the Mayo Clinic by Sriram reporting the malignant mitral valve prolapse, and they described premature ventricular beats originating from the outflow tract and papillary muscle, and then electrophysiological mapping. They demonstrated the site of origin to the papillary muscle, the left ventricular outflow tract, and the mitral annulus. And this is the publication by the group of Mike Ackerman. The story is strange because they collected a series of out-of-hospital cardiac arrest, aborted sudden death with normal heart, apparently normal heart. They did everything, including screening for channelopathies. Then they went back to the echo. They found the existence of prolapse, thickened leaflets, some prolapsing, and so they identified this subset of patient with malignant mitral valve prolapse. And this is the description of the arrhythmias, ventricular ectopy. If you compare patients with aborted sudden death with prolapse versus those with normal valve, you see that there is a statistically significant difference in terms of ventricular bigeminy, non-sustained ventricular tachycardia, sustained ventricular tachycardia, and then premature ventricular complexes of alternating morphologies like the one summarized in this figure. And then there is a table looking back to the literature again, how many series were published with out-of-hospital cardiac arrest and prolapse. Not very many, you see very few. But again, looking to the electrocardiogram, there is always the same feature, inferolateral leads, abnormal T waves, female sex prevalence, and bileaflet mitral valve prolapse. So both leaflets, not only the posterior but also the anterior, involved by thickening and myxoid degeneration. So the question is now, which is the substrate of arrhythmias? In the past, again, many hypotheses dating back to the 80s, the problem of left ventricular remodeling, of course, but also the problem of mechanical lesion due to stretch and friction of the leaflets and the cordon against the endocardium. This can be a trigger also of fibrosis. The associated conduction system pathology, particularly the school of Baratis, Roger Barati, was pointing to the possible association with the conduction system disease. And then already in the 80s, there was the hypothesis of an association with cardiomyopathy, myocardial disease, because arrhythmias were arising from the left ventricular myocardium. So just a few slides summarizing what was done in the past. Look to the inferolateral leads, the T-wave inversion in patients with aborted sudden death and prolapse. Look to the increased QT prolongation, QT interval, The problem of the friction lesion, this is a very famous publication in the 80s in Circulation, pointed to the friction lesion with the endocardium. You see here the fibrosis in the endocardium underneath the posterior leaflet of the mitral valve. And then the hypothesis, with a question mark, that there is a cardiomyopathy associated with prolapse. A sort of syndrome, like the bicuspid aortic valve with the orthopathy, in this setting is the mitral valve with a myocardial disease. So now this is our contribute. We study, you know that in our region, in the northeast of Italy, geographic area, we are running since 30 years a prospective study collecting all the cases of sudden death in the young. I mean, in the age interval between 1 year and 40 years. So all cases occurring in this interval are studied at our referral center. And so we collected now more than 800 cases of young people who die suddenly with cardiovascular diseases. This is our experience. It's not updated, but the percentages are exactly the same. You see that almost 20% are normal hearts, but you recognize also, among the others, mitral prolapse, 8%, which is higher than the one, of course, in the general population. And again, if you look to the distribution of the causes of death, cardiac death, according to the sex of the patient, you see that the prolapse is prevailing in female as compared to male. So it's really a cause of sudden death in young women. So what is going on in the heart of these young women die suddenly? Just a few examples, a couple of examples. This is a 27-year-old female patient who died suddenly without previous history of prolapse and arrhythmias. This is the valve. You see that this is really abnormal. The left atrium was not enlarged. The chordae tendineae were elongated, and she died suddenly. Other cases happened. This is a summary of what we published in Circulation a few years ago. You see that there is a prevalence of the female sex. There was an in vivo diagnosis of prolapse in almost half of the cases due to arrhythmias and palpitation, not due to dyspnea and hemodynamic impairment. In fact, the echocardiogram, when available, documented just a trivial, mild incompetence or even absent mitral regurgitation. Again, 21% of the cases were in beta blocker therapy due to arrhythmias, and despite the beta blocker therapy, they died suddenly. And when you look to the electrocardiogram, available only in 12 cases, in 83% documented negative T-wave inversion in the inferior leads, and the arrhythmias were present with right bundle branch block morphology. This is a limited experience, but a quite constant experience in our series of sudden death cases. This is again another case of a young woman who died suddenly with a previous diagnosis of prolapse. She decided to stop beta blocker therapy because she became pregnant. She died during pregnancy. This is the Holter monitoring she did a few weeks before sudden death. A mitral prolapse was without incompetence in this case. This is the heart, unfortunate autopsy with the typical bi-leaflet involvement, anterior leaflet, posterior leaflet, elongated chordae. This is the posterior leaflet. This is the endocardium with the friction lesion you see here, but also there are areas of fibrosis, I mean scarring, replacement type fibrosis in the left ventricle, particularly at the level of the papillary muscle. Another case, the same story, you see the same arrhythmias, and look to the myocardium, close to the papillary muscle, the extent of fibrosis in the absence of coronary artery disease, normal coronary arteries. There is a scarring, multiple scarring, and this is a higher magnification, the presence of the connective tissue intermingling with the normal cardiac myocytes. This is the panel we published a few years ago. In this series of cases with prolapse, all women who die suddenly, this is the posterior leaflet of the mitral valve. Look to the fibrosis here. This is the posterobasal region. This is a section at the level of the papillary muscle of the mitral valve, and this is an higher magnification. So a constant finding in different cases of sudden death. We measure, of course, the fibrosis. We demonstrated that was statistically significant, so was clearly correlated with prolapse in these cases, not present in other cases without prolapse who died suddenly. So we decided to move from this observation at postmortem to the clinics. We asked our cardiologists, particularly the people involved in imaging and cardiac MRI, to look at the myocardium, in patients with prolapse and arrhythmias. Why not? If this is the substance we find at autopsy, why not to look by contrast-enhanced cardiac magnetic resonance? And we did this study comparing patients with complex ventricular arrhythmias versus those without complex ventricular arrhythmias. They had a cardiac MRI, and this is the result. We were really impressed because Martina Perazzolo, the cardiac magnetic resonance person in charge in Padua, was able to find the same location. You see here, papillary muscle. You see here the posterobasal area with the same signal. We found at autopsy, same location of late enhancement, exactly where we found the fibrosis at postmortem in victims with mitral valve prolapse. And this is another example you see here of the same, a diamagnification, the posterior leaf of the mitral valve, the presence of late enhancement in the posterobasal region, and the patient, in this case, with also aborted sudden death. This is the table we published. You see that when you compare patients with mitral valve prolapse and complex ventricular arrhythmias versus those without complex ventricular arrhythmias, there is a statistically significant difference in terms of presence of left ventricular gadolinium enhancement, and so this is really an association very important with the risk, electric instability, the risk of sudden death. And we concluded the paper, the publication, saying that the prolapse, this kind of prolapse, is an underestimated cause of arrhythmic sudden death, mostly in young adult women, fibrosis of the papillary muscle and infrabasal left ventricular wall, suggesting a stretch by the prolapsing leaflets, because it's exactly where the cordae are going, so it probably is a mechanical issue, is the structural hallmark and correlates with ventricular arrhythmia's origin. Contrast-enhanced cardiac magnetic resonance may help to identify in vivo this concealed substrate for risk stratification. So what was, again, the past, and we were looking back to the history of prolapse. There was a publication coming from the Johns Hopkins, again in the 80s, saying that when you have a prolapse, there is a strong association with a disjunction, an elongation of the annulus of the mitral valve. So the attachment of the posterior leaflet, instead to be here, is, you see, upstream here, close to the left atrium. So elongation of this annulus, according to this paper, is the starting point for a mechanical stretch of the leaflet and progressive thickening of the leaflet. So we started to think that probably the elongation of the annulus is not only the starting point of the thickening of the leaflet, but also the starting point of the mechanical injury at the level of the posterobasal wall of the left ventricle and at the level of the papillary muscle. So we decided to measure the annulus in this patient, the so-called mitral annulus disjunction. You can measure by echo, you can measure by MRI. These are publications by other group, and not only you can measure the elongation of the annulus, but also you can look at the special movement of the annulus and the posterior leaflet, which is called the systolic curling of the posterior mitral ring. We did this, and we exactly found that if you compare prolapse patient with normal valve patient, died suddenly, you see that there is an elongation of the annulus, there is a thickening of the leaflet, and this is statistically significant. And then there is a linear correlation between the so-called annulus disjunction and this curling, and there is a correlation between the annulus disjunction, which is most important, and the extent of fibrosis, late gadolinium enhancement in vivo in patients studied by echocardiography and by MRI. So we close the circle. The disjunction probably is the cause of this stretching at the level of the myocardium, and this accounts for fibrosis at the level of the posterobasal region, the papillary muscle. This is the second part of the study, entitled Morphofunctional Abnormalities of the Mitral Annulus and Arrhythmic Mitral Prolapse. And so we say these mitral annulus abnormalities, together with the click, because the click is the auscultatory phenomenon of the disjunction probably, may identify patients with prolapse who would need arrhythmic risk stratification. So we're trying to close the circle. Of course, there is a lot to do, things to do, because probably starting from a genetic predisposition or a maldevelopment, you have this elongation, you have a thickening of the leaflet due to myxoid degeneration, you have this remodeling of the posterobasal wall with hypertrophy and fibrosis, and then you can have arrhythmias. And this is independent from the problem of hemodynamic regurg and severe or moderate regurgitation. So our hypothesis is that there is an excessive mobility of the leaflets which account for stretch of the inferobasal wall and papillary muscle. The problem, we are in an electrophysiological meeting, what to do? Okay, we found the fibrosis, but what to do? We should implant all the patients with ICD. Of course, the data are not there yet. There are some early publications demonstrating that you can have a reduction in malignant ventricular arrhythmias and appropriate shock of the defibrillator following surgical correction of leaflet mitral valve prolapse, because the concept is that even if you have the substrate there, but you remove the trigger, the continuous trigger, due to the choriotendine and the prolapsing leaflet, you can have an important decrease of electrical instability and onset of arrhythmias. And another, of course, possibility, quite demonstrated by the group of the Mayo Clinic originally, is that you can ablate these arrhythmias, the site of arrhythmias at the level of papillary muscle. I know that is not so easy, but they were able to decrease the onset of arrhythmias in this patient. They did this investigation thinking and believing that the origin of the arrhythmias is not fibrosis, because was not there the information, but is the Purkinje network at the level of the papillary muscle. And probably the two theories, Purkinje fibers and fibrosis, are not exclusive, mutually exclusive, but can be at the same time involved in the electric instability in this patient. So I can conclude my presentation that a patient with mitral valve prolapse and electrocardiographic changes, inferolateral leads, mid-systolic click on auscultation, leaflet thickening, and annulus disjunction probably are those that you have to look for, that they are probably the ones that are at risk of severe arrhythmias and include restratification and contrast-enhanced CMR investigation. The disjunction of the annulus and the systolic column probably are associated with time with hypertrophy of the basal portion of the left ventricle. These trigger fibrosis and account for excessive mobility of the mitral valve apparatus and systolic stretch of the myocardium, which is linked to the valve. Finally, prospective studies are warranted to assess the role of catheter ablation and surgical repair in selected patients with an high arrhythmic burden. Thank you for your attention.